Hello everyone, my name is Ahmed, and I am from Somalia. So today, I am going to talk about diabetic retinopathy. It is a complication of diabetes damaging the retina. This is, back of eye due to high blood sugar level. However, it can cause blindness if we don't take it serious, and left undiagnosed and untreated. But it usually takes several years for diabetic retinopathy to reach a stage where it could threaten your sight. As we know that diabetes is a major concern for healthcare systems throughout the world, diabetes is becoming increasingly common, particularly among working-age individuals. Research says, approximately 1/2 of individuals with diabetes will develop retinopathy in time, with diabetic macular edema being the commonest cause of visual loss. Let's talk about its occurrence. So, the reported prevalence of diabetic retinopathy in people with diabetes varies greatly between studies, and even amongst current populations in the same nation, although it is most likely about 40%. It is more frequent in type 1 diabetes than type 2, and it can cause blindness in up to 10% of cases. PDR affects 5 to 10% of the diabetic population. Type 1 diabetics are most vulnerable, with an incidence of up to 90% after 30 years. Let's talk about pathogenesis. Small blood vessels are particularly susceptible to damage from high glucose levels and DR, which is primarily a microangiopathy. It's also possible that retinal cells will experience direct hyperglycemic consequences. There are several angiogenic stimulators and inhibitors known. In the first group, vascular endothelial growth factor seems to be particularly significant. We have some factors that contribute towards DR, and that is duration of diabetes, poor control of diabetes, and also pregnancy. The most important contributing factor of DR is duration of diabetes. In patients diagnosed with diabetes before the age of 30, the incidence of DR after 10 years is 50%, and after 30 years is 90%. DR rarely develops within 5 years of the onset of diabetes, or before puberty, but about 5% of type 2 diabetics have DR at presentation. It appears that duration is a stronger predictor for proliferative disease than for maculopathy. The Diabetes Control and Complication Trial, DCCT, shows that tight blood glucose control, particularly when instituted early, can prevent or delay the development or progression of DR. Type 1 diabetic patients appear to obtain greater benefit from good control than type 2. Raised HbA1c is connected with an increased risk of a proliferative condition, hence a HbA1c value of 6 to 7% should be the goal, however, 8% in frail elderly patients. Microvascular problems can be minimized by 1/3 by lowering HbA1c by 1%. Pregnancy is sometimes associated with rapid progression of DR. Predicting factors include greater pre-pregnancy severity of retinopathy, poor pre-pregnancy control of diabetes, the control exerted too rapidly during the early stages of pregnancy, and preeclampsia. Approximately 5% with mild DR, and 1/3 of those with moderate DR will progress to PDR during the pregnancy. If substantial DR is present, frequency of review should reflect individual risk and can be up to monthly. Diabetic macular edema usually resolves spontaneously after pregnancy, and need not be treated if it develops in late pregnancy. Nephropathy, if severe, is associated with worsening of DR. Conversely, treatment of renal disease may be associated with improvement of retinopathy and a better response to photocoagulation. Let's talk about its classifications. We do classify DR into 5 stages. Let's talk about them one by one. First is background diabetic retinopathy. In this stage, we see microaneurysms, dot and blot hemorrhages, and exudates on retina. These are generally the earliest signs of DR, and when they persist as more advanced lesions appear. Second is diabetic maculopathy. It strictly refers to the presence of any retinopathy at the macula, but is commonly reserved for significant changes, particularly vision-threatening edema and ischemia. Then we have pre-proliferative diabetic retinopathy, also called as PPDR. When someone is on this stage, we see cotton wool spots, venous changes, intraretinal microvascular anomalies, and often deep retinal hemorrhages. PPDR indicates progressive retinal ischemia, with a heightened risk of progression to retinal neovascularization. Then we have PDR. It is characterized by neovascularization, on or within one disc diameter, of the disc, or new vessels elsewhere, on the fundus. Now we have advanced diabetic eye disease. It is characterized by attractional retinal detachment, significant persistent vitreous hemorrhage, and neovascularization. Common signs of DRR: microaneurysms, retinal hemorrhages, exudates, macular edema, cotton wool spots, venous changes, arterial changes. This all sees on different stages according to the state of an eye. Well, now we have treatment, so either we can treat them by general ways, or second, we have medical way of treatment. In general, we focus on patient education, diabetic control, other risk factors, particularly systemic hypertension, and hyperlipidemia should be controlled in conjunction with the patient's diabetologist. Smoking, and other modifiable factors such as anemia and renal failure, should be addressed as necessary. Another domain of treatment is medically, so for that we have anti-VEGF agents, which we give intravitreal. Laser, photocoagulation, micropulse diode laser, pars plana vitrectomy, and intravitreal triamcinolone. As we always says that prevention is better than cure, so for that you have to educate your patient about track policy, that is, take your medications properly, reach and maintain a healthy weight, add more physical activities in your daily routine. Control your ABC, A1C, blood pressure, and cholesterol level. Last but not the least, kick the smoking habit. Tauta. On diabetic retinopathy. Hope to see you in future. Goodbye.